Hi, welcome back to my channel and welcome to another video. In this video, we will be discussing about the management of asthma. My reference is the 2024 British Thoracic Society guidelines and NICE guidelines. Might differ in based on your local guidelines or based on your country's guidelines. Another thing is this is quite confusing to a lot of students, but what the British Thoracic Society has done in 2014 is quite simplified the treatment of asthma. And in this video, we will not be talking about acute exacerbation of asthma. We are just going to talk about elective cases. Now imagine this, how do you start the treatment of asthma? The first step in treating asthma is always you give this patient with a low dose of inhaled corticosteroids plus formoterol. Right? Now, when we say low dose or high dose, and when we say ICS and formoterol, what do we mean? So let us look at that. So when we are talking about this combination of ICS and formoterol, in the UK, we are talking about budesonide and formoterol, right? And so when we say low dose means a combination of 100 and 6 mcg. And when we say moderate dose, that is the combination of 200 and 6 mcg. So combination of budesonide and formoterol 100 and budesonide 6 mcg. I think it is the reverse. So low dose is 106 mcg, moderate dose is 206 mcgs. Now, so whenever you're starting a patient on a treatment of asthma, so this is what you are going to do first: low dose ICS and formoterol. That is step one. Now, how do you give this? There are two mechanisms of giving this. Imagine this patient has intermittent asthma. Now, what is intermittent asthma? Again, based on GINA guidelines, if anybody has symptoms for less than 1 day per week, or nocturnal symptoms of less than twice per month, who has a period of normal PFR and FEV1 in between attacks, and those in which asthma does not cause problems with activities of their daily living. These are known as intermittent asthma patients. So imagine this: there's a patient who comes to you, he or she tells you that he or she occasionally gets asthma attack. It's not even every day of the week. If it does not even occur every week of the month. Sometimes maybe once every month they have to wake up at night because of asthma, and the rest of the time they are okay. So these patients would not require regular dosing of anti-asthmatic medications. No regular dosing of low dose ICS and formoterol is required, right? So in these patients, you give this drug ICS plus formoterol combination as something they've named as anti-inflammatory reliever therapy. So that means as in PRN basis, or in our country they say SOS basis. So whenever required, as per required basis, you give this drug. What is the dose? It is low dose, meaning 106 mcgs. Understood? So initially you begin with AIR therapy, that is anti-inflammatory reliever therapy as per required. Whenever they have symptoms, they take this medication. Now, if you have worked in medicine clinics or in respiratory clinics or in asthma clinics, you know that these drugs come as inhalers. So inhalers, how do you know how much is 100 mcgs? So you take one puff, 1 to 2 puff as per required, and as much as 6. This can be done for as many as 6 times per day. This is the dose. This is how you start. Now imagine this same patient now starts to develop more frequent symptoms. Now we're talking about moderate persistent and mild persistent and moderate persistent asthma. So if they start to develop more frequent symptoms, now they might require regular dosing of medication, and this regular dosing of medication is known as maintenance and reliever therapy, or MART. So what does this do? You'll give these inhalers in such a way that there is a baseline maintenance, baseline control of symptoms, and sometimes if because of various reasons these get exacerbations, then they also have the option of reliever therapy. So it's not just reliever, you're adding regular maintenance drugs also. How do you start? That is step 2. For step 2, you use low dose MART therapy. So you use low dose MART therapy. Right? Now, what is this? What is low dose maintenance therapy? So we all know what reliever therapy is. Reliever therapy is ICS and formoterol taken 1 to 2 puffs as required up to 6 times per day. Usually it is taken as 1 puff as required, not even 1 to 2. It is taken as 1 puff as required up to 6 times per day. But maintenance therapy means you're taking this combination of ICS plus formoterol, six and 100, one to 2 puffs twice daily, 2 times per day. So you will be despite you have symptoms or not, you will be asking this patient to take inhaler of ICS and formoterol, 1 or 2 puffs twice daily every day. On top of that, if they have symptoms of exacerbation, they can take as reliever therapy also. Again, that is 1 puff PRN up to 6 times per day. So this is how you give low dose MART. Now imagine this also stops working. So imagine this patient, you've started with low dose MART, and now they start having more symptoms again, and you move on to step 3. Up to step 3, what you can do is you will give now moderate dose of MART. Right? So what do you do in moderate dose of MART? We know what maintenance and reliever therapy is. So maintenance therapy is giving ICS and formoterol 1 to 2 puffs twice daily. Right? Now what is moderate dose? Moderate dose means same ICS and formoterol combination, but now you have increased the dose to 6 and 200. You give 2 puffs twice daily. This is moderate dose MART. Now imagine symptoms are still not controlled despite giving moderate dose MART. So you have put this patient on formoterol. In these guidelines, I think you have noticed that I have not mentioned about salbutamol. So you've started this patient on formoterol, and you've started this patient on combination of formoterol and budesonide, 200 mcgs and 6 mcg. You give this patient a maintenance therapy of twice daily plus reliever therapy, PRN, of 200 mcg and 6 mcg as per required, up to 6 times per day. So still the symptoms are not controlled, still patient has regular symptoms, then the patient will come to you. You'll send, before doing step 4 or in step 4, what you will do is you will send this patient for evaluation of eosinophil count, absolute eosinophil count. So absolute eosinophil count plus fractional excretion of nitric oxide, FeNO examination. Now if these things are raised, then you send this patient for asthma clinic. But if absolute eosinophil count and FeNO are not raised, if these are not raised, then you start step 4. And what do you do in step 4? So you've already given this patient with moderate dose of MART. So you continue moderate dose of MART, which is ICS formoterol 206 plus 206. This is done. This is taken as 2 puffs PD. Plus you will give them PRN as per required dosing also. On top of this, you will add either of these 2 drugs. So you will either add a long-acting muscarinic agonist or a leukotriene antagonist. A long-acting muscarinic antagonist and a leukotriene antagonist. What you can do is you can switch between these 2. You can trial and switch between these 2. If one does not work, you can give the other, and that is how you manage in step 4. Imagine still your management does not work and patient still has symptoms. Now this is considering you're working as a GP. In step 5, you have to refer to a respiratory specialist. Why is this patient still not having remission or not having control of symptoms? Has to be investigated by a specialist now. So this is what management of asthma guidelines say. You will start with low dose of ICS and formoterol. Low dose means 106 combination as reliever therapy, as anti-inflammatory reliever therapy. That means you give them as per required basis, 1 puff as per required. That does not work, patient continues to have regular symptoms, you give maintenance therapy. Now you add maintenance to the reliever therapy. So maintenance is again 106 combination, but you give it 1 puff, 1 to 2 puffs BD. That does not work, you increase the dose of MART. Not the 106 combination, you give 206 combination, you give it for 2 puffs twice daily, plus the reliever therapy, that still does not work. Before going on to step 4, you have to reassess the patient, send FeNO and send absolute eosinophil counts. If those are still raised, you have to send this patient for asthma clinic. If those are not raised, you can now add either a LAMA or a leukotriene antagonist drug, and you can switch between these 2 and still trial. Up to that point, you can manage this patient. If that does not work, you have to send this patient for specialist evaluation. I hope you enjoyed this video. If there's any confusion, please write it in the chat box or comment below. If I have made any mistakes, please feel free to correct me in the comments below. And please share this video with those people who want to learn about management of asthma, especially to medical students and those preparing for UK-based exams. I hope this was helpful to you. If you liked this video, please like, comment and subscribe. Thank you and stay tuned for future videos.